Hi guys, now we are going to start the breast. First, in breast part 1, we are going to discuss the anatomy of breast, nipple discharge, what are the risk factors for breast cancer, the risk assessment models and WHO classification for breast cancer. We will be discussing ductal carcinoma in situ, LCIS means lobular carcinoma in situ. After that, we will be discussing breast cancer in details. We will be discussing the investigations done, 8th AJCC TNM classification, and we will be discussing the management of breast cancer. So let's start. First, see the anatomy of breast. You know that breast is modified sweat gland. It's the modified sweat gland. And what is the extent? If you see the top to bottom, it is from second to sixth rib. And from medial to lateral is the lateral border of sternum to the anterior axillary line. So top to bottom, which rib? Second to sixth rib. And from medial to lateral border of sternum to the anterior axillary line. You know that there are two muscles in relation to breast. What are those two muscles? You can see pectoralis major, pectoralis minor. Muscles are pectoralis major, pectoralis minor. Then in relation to breast tissue, there are ligaments. What's the name? Cooper's ligament. What is the importance of Cooper's ligament? You know that in carcinoma breast, whenever there is involvement of Cooper's ligament, what happens? There is dimpling. Involvement of Cooper's ligament, it leads to what? Dimpling. After that, here you can notice breast lobule. Can you tell me what is the basic structural unit of mammary gland? What is the basic structural unit of mammary gland? That is breast lobule. And this lobule, you can notice that here it is going to empty into a ductule, and finally it is going to empty into lactiferous duct. So important point, that breast lobule empties into lactiferous duct via ductule. So question, how many breast lobules are going to empty into one ductule? Approximately 10 to 100. So how many breast lobules? Approximately 10 to 100 breast lobules are going to empty into one ductule. And in one breast, how many lactiferous ducts are there? In each breast, there are approximately 15 to 20. Approximately 15 to 20 lactiferous ducts are there. We discussed about the ribs, what is the extent. So here you can see from top to bottom, it is from second to sixth rib. What is the extent? From top to bottom, it is second to sixth rib, and we discussed that breast is modified sweat gland. So you know it is the modified. This is modified sweat gland, and I'm repeating important point, the basic structural unit of mammary gland, that is breast lobule. 10 to 100 breast lobules are going to empty into ductule, and finally it is going to empty into lactiferous duct. Clear? You know that in breast around areola, what happens? There are multiple sebaceous glands, and these sebaceous glands are going to enlarge during pregnancy. What's the name? It is known as Montgomery tubercles. So what's the name? Montgomery tubercles. You can see how it looks like. So here you can notice that this is the normal nipple. Around the normal nipple, you can see in areola, there are multiple sebaceous glands, and these are, you can notice here, these are enlarged during pregnancy. You can notice here, these are enlarged during pregnancy. And what's the name? The name is Montgomery tubercles. Clear? One. Second, we discussed that what's the cause of dimpling. So in patients of carcinoma breast, there is involvement of one ligament. Which ligament? There is involvement of one ligament. So this is ligament of Cooper. So whenever there is involvement of Cooper's ligament, there is dimpling in carcinoma breast. Another important point related to lymphatic drainage. Can you tell me 85% of lymphatic drainage of breast goes to which lymph node? So it goes to axillary lymph node, and 15% of lymphatic drainage goes to internal mammary nodes. So important point related to lymphatic drainage. If you see 85% of lymphatic drainage of breast goes to axillary lymph node. It goes to axillary lymph node, and you told me that 15% of lymphatic drainage, it goes to internal mammary nodes. Clear? So it goes to internal mammary nodes. Internal mammary nodes. Clear? These are the basic questions related to anatomy which are asked frequently. Now see the very important topic, that is nipple discharge. First you tell me what is the most common cause of bloody nipple discharge. Tell me, bloody nipple discharge, you already know. This is duct papilloma. So most common cause of bloody nipple discharge, that is duct papilloma. So it is duct papilloma. Tell me what are the other causes? Other causes of bloody nipple discharge, you know, it is carcinoma as well as duct ectasia. So other causes, it is carcinoma. Clear? So that is carcinoma. And what else? You told me just now, duct ectasia. That is duct ectasia. Right? Second question, most common cause of serous nipple discharge. You have seen this kind of history that a young female age approximately 40 years, she is coming to you with nipple discharge, serous, coming from multiple ducts, and she is complaining of what? Bilateral cyclical mastalgia. There is lumpy breast. So obviously what is this? This is fibrocystic disease. Clear? So serous nipple discharge, what's the most common cause? It's very important. It is fibrocystic disease. Fibrocystic disease, and in this case the discharge is from multiple ducts. There is associated bilateral cyclical mastalgia, right? What are the other causes? It can be caused by carcinoma also. So carcinoma is another cause, and it can be caused by duct ectasia also. So other causes are carcinoma and duct ectasia. Right. Now you tell me, what's the cause of greenish, blackish, grumous, pultaceous nipple discharge? What is grumous or pultaceous? It is thick paste-like, just like toothpaste. So greenish, blackish, grumous, pultaceous nipple discharge. It is seen in duct ectasia. So this is seen in duct ectasia. Duct ectasia. So I'm repeating the questions which are asked frequently. They ask, what is the most common cause of bloody nipple discharge? You know, duct papilloma. What is the most common cause of serous nipple discharge? You know, it is fibrocystic disease. And any kind of nipple discharge, what? Any kind of nipple discharge is possible in duct ectasia. So important point, any kind of nipple discharge. So any kind of nipple discharge. Clear? That's possible in duct ectasia. So you saw there is bloody nipple discharge, serous, greenish, blackish, grumous, pultaceous nipple discharge. Got it? These are the causes. Now, how to investigate? If a patient is coming to you with nipple discharge, if you suspect breast cancer, what is the first investigation done? So first investigation done in a suspected case of breast cancer. First investigation done in suspected case of breast cancer. Obviously, that's mammography. If it's a suspected case of breast cancer, obviously it's mammography. And suppose patient is having nipple discharge, what kind of bloody? If bloody nipple discharge is there in the duct, you inject the dye, take X-ray. What's the name of this investigation? Yes, ductography. What's the name? Ductography. So for bloody nipple discharge, we are going for ducto. What? We are going for ductography. Ductography. In exam, they ask the findings of ductography. See the findings. Suppose you are performing the ductography and you are going to find this kind of filling defect. Can you see here? There is single smooth intraluminal filling defect. Can you notice here? There is single smooth intraluminal filling defect. It is seen in papilloma. It is seen in duct papilloma. So single smooth intraluminal filling defect seen in duct papilloma. See the next one. There are multiple irregular filling defect. You can see here multiple irregular filling defect, and this is seen in carcinoma. You can notice multiple irregular filling defects seen in carcinoma, and here you can notice what? The duct is dilated, and obviously if duct is dilated, you can tell me what is the diagnosis? Ectasia. So dilated duct, it means it is ectasia. Clear? Now how we are going to manage? This is one of the frequently asked question. If patient is having duct papilloma, so it's a benign condition and there is involvement of a duct, you just excise that duct. Excision of involved duct only. What is the name of this surgery? This is known as microdocectomy. So you can see here, whenever there is excision of involved duct only, right? So what we go for? We go for excision of involved duct. What is the name of this surgery? This is known as microdocectomy. What is the name? This is one of the frequently asked question. In duct papilloma, we just excise the involved duct, so it's microdocectomy. What about duct ectasia? In duct ectasia, we go for conical excision of involved duct, and that conical excision, tell me what's the name? Conical excision, that is Hadfield's operation. So this is also asked frequently. Here you can see in this image, you can notice that the patient is having this duct ectasia, and what kind of surgery is done? You can see here, we are going for conical excision. So what is the conical excision of involved duct only? And that is Hadfield's operation. So I'm repeating. For duct papilloma, we go for microdocectomy, and for duct ectasia, we go for Hadfield's operation. Before discussing breast cancer in detail, two, three important points I'm going to discuss. You know that majority of malignancies are either carcinomas or sarcomas. In carcinomas, there is adenocarcinoma, there is squamous cell carcinoma, right? You know that adenocarcinoma, these are arising from glands. So breast is a gland, thyroid is a gland, prostate is a gland, ovary is a gland, endometrium is a gland. So from these glands, adenocarcinoma is arising. Got it? What is the difference between adenocarcinoma and squamous cell carcinoma in the terms of risk factors? If you see, in general, not all, but in general, adenocarcinomas, these are more common in high socioeconomic status. And what is related to high socioeconomic status? High fat diet and obesity. So adenocarcinoma, it is more common in high socioeconomic status, and this is related to what? High fat diet and obesity. Squamous cell carcinoma, usually it is more common in low socioeconomic status, and you know that it is related to one virus. Which one? HPV. That's why you know that squamous cell carcinoma of oral cavity, squamous cell carcinoma of esophagus, squamous cell carcinoma of cervix, squamous cell carcinoma of penis, anal canal, all these are more common in low socioeconomic status, and these are associated with human papilloma virus infection. So one thing I want to tell you, breast cancer, it's adenocarcinoma, more common in high socioeconomic status. So in this chapter, you're going to notice that the risk factors will be revolving around what? High socioeconomic status. Clear? Now see one by one. First, advancing age. It's a risk factor for any kind of malignancy. One of the most important risk factor for any malignancy is advancing age. Origin, she belongs to, yes, Western countries. So origin is from Western countries. Origin, it's from Western countries. Clear? Socioeconomic status, obviously, patient belongs to high socioeconomic status. Patient belongs to high socioeconomic status. You know that in high socioeconomic status, females, what happens? There is alcohol intake. So high socioeconomic status, females, there is alcohol intake, high fat diet, and obviously high fat diet, it leads to obesity. Both of these are risk factors. After that, states of hyperestrogenemia. Can you tell me what are the states of hyperestrogenemia? This is also revolving around high socioeconomic status. Why? Early menarche, late menopause, nulliparity, late age at first full-term pregnancy. You know, states of hyperestrogenemia. What? Early menarche, you know, early menarche, clear? Late menopause. So there is late menopause, clear? So early menarche, late menopause, nulliparity. This patient is not having any kids, nulliparity, and late first full-term pregnancy. There is late age, late first full-term pregnancy, first full-term pregnancy, full-term pregnancy. Clear? You have seen lots of examples in Bollywood. Lots of actresses are going to develop breast cancer. So you know that what happens, what is the age of marriage at present? Usually in high socioeconomic status, you have seen it is 30 plus. So early menarche, late menopause, nulliparity, late first full-term pregnancy. These are states of hyperestrogenemia. And you know that high estrogen is a risk factor for breast cancer because estrogen is having positive effect on breast cancer cells. Next, positive family history, and especially on which side? On the maternal side. It's on the maternal side. So positive family history on the maternal side, especially if mother is having breast cancer, if patient's sister is having breast cancer, or if mother's sister, means in Hindi, Mausi, mother's sister is having breast cancer. So if breast cancer is there in mother, in Mausi, in sister, right? These females are high risk females if there is positive family history. Next, personal history of malignancy. Can you tell me which malignancies? Adenocarcinomas. So which adenocarcinomas in females? You know, carcinoma endometrium. Which one? You know, this is carcinoma endometrium. And which one? Carcinoma ovary. So carcinoma endometrium and carcinoma ovary. After that, genetic mutations which are very, very important, BRCA1, BRCA2. You know that both BRCA1 as well as BRCA2 are going to increase the risk of breast cancer in both males and females. I'm repeating, both BRCA1 as well as BRCA2 are going to increase the risk of breast cancer in both males and females. But BRCA1 mainly in females, BRCA2 mainly in males. You see, genetic mutations. So BRCA1 and BRCA2. So we discussed that both BRCA1 as well as BRCA2 are going to increase the risk of breast cancer in both males and females. BRCA1 mainly in females. What? mainly in females, BRCA2 mainly in males. So how to remember? Ladies first. So BRCA1 mainly in females. So it's very easy to remember, ladies first. Right? After that, hormone replacement therapy. So whenever you are going to replace or give heavy dose of estrogen or high dose of estrogen and progesterone, it is going to increase the risk. So hormone replacement therapy is a risk factor. And history of therapeutic radiation exposure. What do you mean by therapeutic radiation exposure? Whenever we are giving radiotherapy in some malignancy, usually the dose is 40 to 60 gray. And this high dose radiation, 40 to 60 gray, increases the risk of breast cancer. So these are the risk factors for breast cancer. OCPs as well as smoking, again, these are considered as risk factor. Clear? OCPs as well as smoking, but not considered significant risk factor, though these are going to increase the risk of breast cancer. In a latest exam, this question was asked that breast-related conditions which are more common in smokers. You have seen in Indian females from the last 4-5 years, there is increasing tendency of smoking. So what are the conditions whose risk is increased by smoking? Obviously, we discussed that it is going to increase the risk of CA breast. Apart from CA breast, it is going to increase the risk of duct ectasia. Yes, duct ectasia we discussed. There is greenish, blackish, grumous, pultaceous nipple discharge. Mondus disease. What is Mondus disease? There is superficial thrombophlebitis of inframammary vein, which is also known as string phlebitis. Which is also known as string phlebitis. Clear? So, superficial thrombophlebitis of inframammary veins, lateral thoracic and thoracoepigastric, that is Mondus. Zuska's disease. What is the problem here? Patients are having recurrent periductal mastitis. And again, this is more common in smokers. So Zuska's disease, what's the problem? Patients are having recurrent periductal mastitis. So patients are having recurrent what? Recurrent periductal mastitis. Recurrent periductal mastitis. Clear? Now, which factor is protective? So you know that long duration of breastfeeding is protective for breast cancer. What are the commonly used risk assessment models of carcinoma breast? One is Gale model, one is Klaus model. You tell me out of these two, which one is most commonly used? Gale model and Klaus model, which one is most commonly used? It is Gale model. Which model provides more information about family history? So it's the Klaus model, which is going to provide more information related to family history. So it provides more information related to family history. Right? How to remember? The mnemonic is Nana in jail. Gale, Nana in jail. Gale, Nana in jail. Clear? So Gale, that is Nana in jail. How to remember? N means number of breast biopsies done. A, what was the age at Minak? N, number of first degree relatives with breast cancer. And A, age at first live birth. So Nana, that is number of breast biopsies. Right? A, age at Minak. N, number of first degree relatives with breast cancer. And A, age at first live birth. So these are the components of Gale, Nana in jail. Klaus model. So what it is based on? Klaus model, it is based on decades of life, first and second degree relative. In this case, can you see only first degree relative? But here, first and second degree relative with breast cancer. And what's the age at diagnosis? Clear? So Gale model, Klaus model, which one is most commonly used? Gale model. Which one is going to provide more information about family history? Klaus model. Now see the WHO classification of breast cancer. According to WHO classification, there are 3 categories. What are the 3 categories? First, in situ carcinoma. And in situ carcinoma, we are going to include DCIS and LCIS. Ductal carcinoma in situ, lobular carcinoma in situ. Clear? After that, second category, invasive cancer. And third, Paget's disease of nipple. Right? Now see, in invasive cancer, can you tell me which one is the most common type? It's the ductal carcinoma. The most common type, that is ductal carcinoma. So second question which is asked, what is the least common type of breast cancer? Tell me, what is the most common type of thyroid malignancy? Papillary. So that is the least common in breast, papillary. So papillary carcinoma, that is least common. Least common. Second, you can see ductal, then there is lobular carcinoma, tubular carcinoma. This is also known as cribriform carcinoma. Tubular, what's the other name? Also known as cribriform. Tubular, that is also known as cribriform carcinoma. Mucinous Mucinous, this is also known as colloid carcinoma. You can see the term is self-explanatory. Here, there is excessive mucin production. The kind of invasive cancer which is associated with excessive mucin production. What's the name? Mucinous. So, mucinous carcinoma, also known as colloid carcinoma. So, mucinous carcinoma, also known as colloid. After that, there is medullary carcinoma, then papillary, then metaplastic, and inflammatory breast cancer. That's the most dangerous. Why? Because you know that inflammatory breast cancer is the most malignant breast cancer, having worse prognosis. So, this one, this is most malignant inflammatory breast cancer. This is most malignant, and you know that this is having worse prognosis. Worst prognosis. Can you tell me the just opposite of inflammatory breast cancer means which one is least malignant, having best prognosis? That's tubular. This was asked in latest exam. Tubular or cribriform carcinoma. This is least malignant. This one is least malignant, and you know it is having best prognosis. So it is least malignant, having best prognosis. Having best prognosis. Clear? These are one-liner questions which are asked frequently in relation to WHO classification and in relation to types of breast cancer. Now see the carcinoma in situ. First, DCIS, what's the name? Ductal carcinoma in situ. So you know that there is high risk of progression to ductal carcinoma in situ means invasive ductal cancer. It is arising from duct. So there is high risk of progression to ipsilateral in the same breast, ipsilateral invasive ductal cancer. Ipsilateral invasive ductal cancer. Okay, one thing, you know that ducts are present in both males and females. In the breast of both males and females, ducts are present. It means DCIS as well as invasive ductal cancer, it is seen in both males and females. But you know, lobules are only seen in females. That's why lobular carcinoma, it's only seen in females. So important point, ducts, these are present in both males and females. Since it is present in both males and females, that's why DCIS, ductal carcinoma in situ, as well as invasive ductal cancer. Invasive ductal cancer, these are seen in both males and females. But lobules, these are exclusively seen or only seen in females. That's why lobular carcinoma, it is only seen in females. Lobular carcinoma, that is only seen in females. What is the problem? If you see, DCIS, it is going to increase the risk of breast cancer in ipsilateral breast only. It increases the risk of ipsilateral invasive ductal cancer. But what's the problem with lobular carcinoma? Lobular carcinoma in situ, LCIS, that is multicentric and bilateral. And since it is multicentric and bilateral, it means it is going to increase the risk of bilateral breast cancer. So DCIS increases the risk of ipsilateral breast cancer. LCIS, multicentric and bilateral, so it is going to increase the risk of bilateral breast cancer. If you see the classification of DCIS, it is based on two special features. What? Nuclear grade and necrosis. So classification of DCIS, it is based on nuclear grade and necrosis. Clear? Nuclear grade and necrosis. So it is further divided into low grade DCIS and high grade DCIS. How to remember low grade? CPM. You know there is a political party, CPM. So C, cribriform, P, papillary, M, micropapillary. So CPM, what are the types? It is cribriform, low grade. Cribriform, clear, papillary and micropapillary. So this is cribriform, papillary and micropapillary. Clear? So cribriform, papillary, micropapillary. High grade DCIS, high grade, clear? Here we are going to include solid and comedocarcinoma. So it is solid and comedo. So it is solid and comedocarcinoma. Carcinoma. Clear? So solid and comedocarcinoma, this is included in high grade DCIS. These are frequently asked questions. After that, if you see the investigation, tell me what is the characteristic feature of DCIS? In DCIS, there is presence of microcalcification. Another important point, since it's a soft tissue abnormality, can you tell me what is the most sensitive investigation for detection of DCIS? Tell me, most sensitive. Yes, MRI. But what is the problem with MRI? You know that MRI is having poor sensitivity for detection of calcification. So we have to read the question carefully, that if the question is asked most sensitive investigation for DCIS, then it is MRI. MRI is having poor sensitivity for calcification. That's why if the question is asked most sensitive investigation for microcalcification, then it is mammography. Then it is mammography. It's mammography. Clear? So what we see in DCIS on mammography, important point, microcalcification. Now here you can notice this is mammography of DCIS. In this case, what you can see, this is the mediolateral oblique view, and you can notice that these are microcalcifications. So you can see these are the microcalcifications. Got it? So these are microcalcifications. So on the mammography, we are going to find microcalcification. So most sensitive investigation for microcalcification, mammography. And if it is said most sensitive investigation for DCIS, then you are going to mark MRI. How we are going to manage? Imagine it's non-palpable DCIS which cannot be felt. So here, how you are going to excise it? You have to excise it by needle localization technique. And after excision, the specimen which is removed, we have to perform the specimen mammography, and we are going to match it with previous mammography. So how you are going to excise a non-palpable DCIS? This is excision. It is excision by needle localization. Excision by needle localization, clear? Needle localization with specimen mammography, whatever the specimen you have removed. Yes, you perform the mammography. So with specimen mammography, and we are going to match the specimen with previous mammography. Previous mammography. Suppose patient is having low grade DCIS. In this case, what is sufficient? Only lumpectomy. And if patient is having DCIS with limited disease or it is high grade, in that case we have to go for lumpectomy plus radiotherapy. So here, if low grade DCIS is there, we go for what? Lumpectomy. Lumpectomy. And if there is limited disease or high grade DCIS is there, so apart from lumpectomy, we give radiotherapy also. Next is lobular carcinoma in situ. Lobular, so it arises from terminal duct lobular unit. Terminal duct lobular units. And since lobules are seen only in females, so it is seen only in females. So it arises from terminal, what's the origin? Is the terminal. So that's terminal duct lobular unit. Duct lobular unit. Lobular unit. And we discussed that it is only seen in females. Only seen in females. Clear? So it is only seen in females. We discussed that this is multicentric and bilateral. And since it is multicentric and bilateral, that's why it is going to increase the risk of bilateral breast cancer. It means, what's the problem with LCIS? Actually, it's a marker of increased risk for bilateral breast cancer. It is going to increase the risk of bilateral breast cancer. It increases the risk of bilateral breast cancer. It means it's a marker. It's a marker for increased risk of bilateral breast cancer. Now see the important points related to pathology. In LCIS, we are going to find cytoplasmic mucoid globules, and there is histologic hallmark. And what is that histologic hallmark? Indian file pattern. What is Indian file pattern? Here, there is tendency of tumor cells to invade in linear strand. So in linear strands, there is tendency of tumor cells to invade. That is Indian file pattern. So this is histologic hallmark. This is the histologic hallmark. Both of these questions are asked in exam. What? That there is cytoplasmic mucoid globules and tendency of tumor cells to invade in linear strands. What? Indian file pattern. How it looks like, you can see here. This is the Indian file pattern. You can see the tendency to invade in the linear strands. Tendency to invade in linear strands. That's the Indian file pattern. This is the histologic hallmark of LCIS. Coming to the clinical features, what is the most common presentation? These patients are having lump, but here the lump is having ill-defined margins. So most common presentation, patient is having lump, but patient is having ill-defined margins. Lump is having ill-defined margins. Ill-defined margins. Clear? We discussed just now DCIS, and on mammography, what kind of calcification was there? Microcalcification. What is the characteristic feature of LCIS here? There is neighborhood calcification. Important point you have to remember. In DCIS, microcalcification. In LCIS, it is neighborhood calcification. So this term you have to remember. Here we get neighborhood calcification. Clear? So there is neighborhood calcification. Means calcification is seen in the neighborhood. So neighborhood calcification. Okay, we discussed that it's a marker for bilateral breast cancer. So what are the treatment options? Either we can go for observation or we can go for chemo prevention. You know that in chemo prevention, which drugs we give? We give tamoxifen, we give raloxifene. So what? Here, for the treatment, we have observation. So we have to go for either observation or we advise chemo prevention. And in chemo prevention, we give which drug? We give SERM, chemo prevention. So which drugs we are giving in chemo prevention? Tamoxifen, raloxifene. Tamoxifen and raloxifene. Clear? So we are giving tamoxifen or raloxifene. The second advice is patient can go for prophylactic bilateral mastectomy. Why? Because there is increased risk of bilateral breast cancer. So patient can go for prophylactic bilateral mastectomy. Clear? Prophylactic bilateral mastectomy. So that's the option for management of LCIS. So now we are going to discuss the breast cancer in detail. First, can you tell me what is the most common histological type? We discussed already that it is arising from the gland. So obviously it is adenocarcinoma. So the most common histological type, that is adeno. Clear? So this is adenocarcinoma. This is adenocarcinoma. And we discussed the subtype also. It is arising from the duct, mainly from the duct. So the most common subtype, this is invasive ductal cancer. So most common subtype, that is invasive. This is invasive ductal cancer, right? Now you tell me, we already discussed what is the least common type. So we discussed that in thyroid, the most common type is papillary, and that is least common in breast. So in breast, least common is papillary. So what is the least common subtype? That is papillary. Least common, that is papillary. After that, we discussed that what is the most malignant having worse prognosis? This is inflammatory breast cancer. And which type is least malignant having best prognosis? That's tubular. That's tubular. Clear? Now, what is the most common site of breast cancer? Tell me. It is more common in right breast or left breast? More common in left breast. And in breast, most common site, which quadrant? So it is upper outer quadrant. Tell me why? Because there is maximum amount of breast tissue in upper outer quadrant. That's why it is the most common site. Tell me, what is the least common site? Tell me least common. So you know that in the lower inner quadrant, there is least amount of breast tissue. That's why it's the least common site. So here in this image, you can notice that this is upper outer quadrant, which is the most common site. So that's the upper outer quadrant because there is maximum amount of breast tissue, and the least common site, it is lower inner quadrant. So the least common site is lower inner quadrant. Why? Because there is least amount of breast tissue. Now see the route of spread. Before discussing the route of spread, you have to remember 2-3 principles. First, you know that there is carcinoma, there is sarcoma, and in carcinomas, there is hematogenous spread also, there is lymphatic spread also. In sarcomas, usually there is exclusively hematogenous spread. In sarcomas, there is exclusively hematogenous spread. Now coming to the carcinoma. In adenocarcinoma, what is the most common route of spread? It is lymphatic. So breast is also adenocarcinoma here. What is the most common route of spread? You know, the most common route of spread in CA breast, it is lymphatic. The most common route of spread, that is lymphatic. Now, what is the most common site of metastasis? It is bones. Can you tell me which bones? So in bones, we discussed already which bones is the lumbar vertebra, followed by femur, followed by thoracic vertebra. How to remember? Mnemonic is LFT. What is this? This is LFT. So how to remember? It is lumbar vertebra. So that is lumbar vertebra, clear, followed by femur, followed by thoracic vertebra. So lumbar vertebra, followed by femur, followed by thoracic vertebra. LFT, how to remember? It is LFT, clear? Now coming to the most common cause of death. See, metastasis usually occurs in 4 organs. What? Liver, lungs, brain, bone. I'm repeating, liver, lungs, brain, bone. Metastasis occurs in liver, lungs, brain, bone. Out of these, usually death doesn't occur from bone metastasis. Death usually occurs from liver, lungs, and brain metastasis. So what? Most common cause of death here, it is malignant pleural effusion, but the most common site of metastasis is bone. So here, most common cause of death, that's malignant pleural effusion. Clear? So this is malignant pleural effusion. Clear? Malignant pleural effusion. Nowadays, questions are asked on the basis of pathway of spread of cancer cells. So see how this breast cancer cell is going to spread. First, what is the most common site of breast cancer? Tell me. Upper outer quadrant. Via this upper outer quadrant, it is going to invade the posterior intercostal vein. And whenever there is involvement of posterior intercostal vein, it is connected to the Batson plexus. You know, Batson plexus is the vertebral venous plexus. So from Batson plexus, the tumor goes to lumbar vertebra. So there is involvement of lumbar vertebra. After that, it is connected to the dural venous sinuses where? Here, near cervical vertebra. So via this, it goes to the dural venous sinuses. From dural venous sinuses, it goes to the leptomeninges, and from leptomeninges to the brain. So see the pathway. In this image, you can notice breast cancer cells. It is going to invade. This question was asked in NEET PG. Posterior intercostal vein. After that, there is invasion of Batson plexus. Via Batson plexus, there can be involvement of lumbar vertebra. You know, that's the most common site of metastasis, or dural venous sinuses. From dural venous sinuses, leptomeninges. From leptomeninges, brain. So I'm repeating the questions which are asked. First, via which vein there is involvement of Batson plexus? Posterior intercostal vein. Via which plexus there is involvement of lumbar vertebra? Batson plexus. Most common site of metastasis in CA breast, lumbar vertebra. Via which sinuses there is involvement of leptomeninges, dural venous sinuses. And next question, what is the most common primary? Tell me, what is the most common primary for leptomeningeal metastasis? Means in the leptomeninges, malignant cells came from which malignancy? CA breast. So most common primary for leptomeningeal metastasis, CA breast. And another question which is asked, most common primary for brain metastasis, carcinoma lung followed by carcinoma breast. So what is the most common primary? Tell me, most common primary for brain metastasis. So most common primary for brain metastasis. Clear? This is carcinoma lung followed by carcinoma breast. So this is CA lung. It is CA lung followed by CA breast. CA breast. So all these questions are asked frequently. This is the pathway of spread of breast cancer cells. Now see the problem. What is the presentation? Suppose this is the patient, right? Patient develops the lump. Initially what happens? There is lump in the breast. And if patient is educated, the moment she is going to notice the lump, she comes to us. But what happens if patient is in the rural area, patient is not very educated, she is just ignoring the lump. So first, what is the most common presentation overall? It's the lump. If patient comes early, suppose this patient is not coming to you. If the patient is not coming to you, the size of lump keeps on increasing. And when size of lump keeps on increasing, after that what will happen? The shape of breast is going to change. And that is what? Architectural distortion. So shape will be changed, architectural distortion. After that what will happen? See, there is asymmetry. Both breasts are not looking similar, so there is asymmetry. After that, the malignancy is going to involve the breast skin. So there will be skin fixity. It is going to involve the nipple. There will be nipple retraction, deviation, ulceration. And it is going to involve the chest wall. So what will happen? Fixity to chest wall. So there is asymmetry because of involvement of skin fixity. There is fixity to chest wall. And if nipple is involved, what will happen? Nipple retraction. There is nipple retraction, nipple deviation or nipple ulceration. So nipple retraction, deviation or ulceration. These are the findings. Clear? These are the findings. Suppose patient is having metastasis. Imagine patient is having brain metastasis. There is headache, bone metastasis, backache, lung metastasis, dyspnea, liver metastasis, jaundice. Apart from this, there will be anorexia and weight loss. So what are the other manifestations if patient is having advanced and metastatic disease? See, there can be headache because of brain metastasis. There can be backache because of bone metastasis. backache because of bone metastasis. There can be dyspnea because of involvement of lungs or there is pleural effusion. There can be jaundice if there is liver metastasis. Apart from all these, you know that patient will be having anorexia and weight loss. What else? Anorexia and weight loss. Clear? So anorexia and weight loss. Got it? Anorexia and weight loss. These are the signs and symptoms of advanced and metastatic disease. So this is history. Now we are going to perform the examination. See the findings. In this image, you can notice what? That there is a retracted nipple. Can you see here? See the nipple. One of the finding we discussed, there is retracted nipple. In this case, you can notice the first one here, there is pudgy orange. Now question, what is the cause of pudgy orange? You can see these are the lymphatics. In the breast skin, there are lymphatics. What is the problem? These lymphatics are obstructed by these tumor cells. So the tumor cells are going to obstruct the lymphatics. So question is asked, pudgy orange. This is one of the frequently asked image-based question. I'm repeating. This is one of the frequently asked image-based question. Every year in each and every paper, the question is asked. So pudgy orange is the most conspicuous or most obvious sign of breast cancer. Means just by looking at the breast, if this sign is there, you can tell that the patient is having breast cancer. So important point related to pudgy orange. What's the cause? It is caused by lymphatic permeation, or obstruction by tumor cells. So lymphatic permeation or obstruction by tumor cells. Right? We discussed that this is most conspicuous or obvious sign of breast cancer. So this is most conspicuous sign. This is the most conspicuous sign. Clear? Of breast cancer. Most conspicuous sign of breast cancer. That is pudgy orange. You can see here, this is pudgy orange. I'm repeating again. This is one of the most commonly asked image-based question. After that, in this image, you can notice what? That there is dimpling. Can you see here? What is dimpling? You have seen dimples. Skin depression. Can you see? Yes. So skin depression. So that's dimpling. So dimpling is skin depression because of involvement of ligament of Cooper. So it is because of involvement of ligament of Cooper. That is dimpling. So dimpling, it is because of involvement of ligament of Cooper. So here you can notice that. In this case, you can notice that here there is dimpling because of involvement of ligament of Cooper. In puckering also, what happens, you can see here, in the puckering, what happens, there is wrinkling of the breast skin. In this image, you can notice, there is wrinkling of breast skin. Again here, there is involvement of ligament of Cooper. So wrinkling of breast skin. This is wrinkling of breast skin. And again here, there is involvement of ligament of Cooper. That is puckering. So dimpling and puckering both are because of involvement of ligament of Cooper. After that, you can see this is cancer in cuirass. What you can notice in this image, you can notice that there are multiple nodules. There are ulceration. So multiple nodules and ulceration involving breast skin, chest wall, that is cancer in cuirass. What? Multiple nodules and ulceration. So there are multiple nodules. You can see. So multiple nodules and ulceration involving breast skin and chest wall. The name, this is important, cancer in cuirass. I'm repeating again, pudgy orange, one of the frequently asked image-based question. So what did you see here? If a patient comes to you, take the history, you perform the examination. So first clinical signs and symptoms. After that, we send the patient for investigation, imaging. What is the first investigation done in a suspected case of breast cancer? Mammography. And another investigation which can be done, that's ultrasound. After that, for confirmation, we are sending the patient for tissue sampling. So we go for biopsy or FNSC. So what is the name of this assessment? Tell me. Triple assessment. So you can see here, what are the components of triple assessment? Clinical. What? Clinical signs and symptoms. So clinical signs and symptoms. In imaging, we are sending the patient for mammography. So what are the investigations done? Mammography or second, ultrasound. And for tissue sampling, what is the biopsy or FNSC? So this is triple assessment. Can you tell me how much is the positive predictive value? You can't believe it is 99.9%, means almost 100%. So triple assessment, yes. How much is the positive predictive value, guys? Positive predictive value, 99.9%, almost 100%. Now see the investigations we discussed. What is the first investigation done in a suspected case of breast cancer? You already told me mammography. You told me already that's mammography. Clear? And now you tell me what is the investigation of choice for diagnosis of breast cancer? Confirm it. So it's biopsy. What are the other names of biopsy? True cut biopsy, core cut biopsy, needle biopsy. So what are the names? It's known as biopsy, also known as true cut biopsy, also known as core cut biopsy. So there is true cut biopsy needle, core cut biopsy. Since you are using the needle for biopsy, needle biopsy. Needle biopsy. I'm telling you, examiners at the place of biopsy mention true cut biopsy. Sometimes they mention core cut biopsy or needle biopsy. So mark the correct answer. Now see the differences in FNAC and biopsy. What is FNAC? Is the fine needle aspiration cytology. So obviously the needle is smaller. Here, what's the size of needle? It is 22 to 26 gauge. So it is 22 to 26 gauge. Clear? Size of needle. Here it is fine needle aspiration cytology. So that's why you need experienced cytopathologist. What is the big problem? Since only cells are being aspirated and examined, so actually it's difficult for you to differentiate DCIS from invasive ductal cancer. So if it's difficult for you to differentiate DCIS from invasive ductal cancer, that's why there are high chances of false positive or false negative results. There are high chances of false positive or false positive or false negative results. Since you are just going to aspirate the cells, so hormone receptor status, it is difficult to assess. So hormone receptor status, yes, it's difficult to assess. Is difficult to assess, right? So but what we do in biopsy, see the size of needle, it's a bit larger. It's 14 to 16 gauge. 14 to 16 gauge. Right here, you are going to take the chunk of tissue. So here, since you have chunk of the tissue, what happens? Diagnosis is made easily. So diagnosis is made easily. It is made easily. Clear? Easily you can differentiate DCIS from invasive ductal cancer. Why? Because you have chunk of tissue. So easy to differentiate DCIS from invasive ductal cancer. From invasive ductal cancer. So it is easy to differentiate DCIS from invasive ductal cancer. You can easily assess hormone receptor status. So you can assess easily. So it is assessed easily. Clear? But only problem, since the size of needle is a bit large, so biopsy is a bit more painful. It's more painful in comparison to FNAC. What are the other names of biopsy? True cut biopsy, core cut biopsy, needle biopsy. Now see the mammography, which is very, very important. First, to tell me what is the investigation of choice for screening of breast cancer? Mammography. So this is investigation of choice for screening of breast cancer. At what age screening should be started? Previously, it was said that 40 years, but according to new recommendation, it is 45 years. So it should be started at 45 years of age. And once you're going to start it, after that, it should be recommended annually. So it should be done annually. So started at 45 and it should be done annually. Afterwards, what is the type of X-ray used here? The name of X-ray is very important. You have to remember it is Brehm straw lung. Name of X-ray, that is Brehm straw lung. Clear? So it is Brehm straw lung X-ray. How much is the radiation exposure? It's 0.1 centigrade per study. It's very, very low. How much? It's 0.1 centigrade per study. In one of the latest exam, this question was asked that one mammography is equal to how many chest X-ray? One mammography is equal to 4 chest X-ray. One mammography is equal to 4 chest X-ray. Now, can you tell me how much is the radiation exposure? 0.1 centigrade per study. It means it's so small that mammography itself is not going to increase the risk of breast cancer. But we discussed therapeutic radiation exposure is a risk, means 40 to 60 gray, high dose radiation exposure is a risk. Mammography doesn't increase the risk of breast cancer. See the mammography apparatus and how we are going to perform the mammography. In this image, you can see that this is the rotating anode, right? This is the compression plate, and here you can see this is the film, right? You can see the breast is placed between the compression plate and the film. right? So what is the name of this view? This is craniocaudal view. So in this craniocaudal view, what you're going to assess, can you see? In the craniocaudal view, you are going to assess the medial aspect of breast, and this compression plate is coming, so it is going to compress the breast. So what we are going to assess in craniocaudal view? Medial aspect of breast and breast compression. So first, craniocaudal view. Second, there is mediolateral oblique view. In this image, you can notice that this is mediolateral oblique view, and see the picture. So what is the advantage of mediolateral oblique view? In the mediolateral oblique view, maximum amount of breast tissue is assessed, and simultaneously we are going to assess what? Axillary tail. So in this image, you can notice that maximum amount of breast tissue is assessed, and simultaneously you are going to assess what? Axillary tail. We are going to assess the axillary tail as well as maximum amount of breast tissue. What's the name? Mediolateral oblique view. Now let me tell you, it's very easy. Actually, mammography is just the X-ray of breast. Only radiation dose is different. So what you have to do, just have this thing in your mind that you are doing the X-ray of breast. So what are the findings which are suggestive of malignancy? Suppose you see this mammography and tell me the nipple. Can you see nipple? Nipple is retracted. So tell me, it is suggestive of benign disorder or malignancy? Obviously malignancy. So first you can see that nipple is retracted or inverted. Second, you can see here that this is the breast tissue. In the breast tissue, what you're going to notice, behind breast tissue, there is a muscle known as pectoralis major. So in between the breast tissue and pectoralis major, the space, and this space is known as what? Retromammary space. Let me tell you, in carcinoma breast, there is obliteration of this retromammary space. Another thing which you are going to notice, that the opacity is having irregular margin. What? Irregular margin of opacity, you can see here. And what else? You can notice microcalcification. What else? You can notice skin thickening. So here you can notice that these are the microcalcification. There is irregular opacity. Here the nipple is inverted or retracted. There is skin thickening. And if there is obliteration of retromammary space, all these findings are suggestive of carcinoma. Clear? Now see the findings in benign disorder. You know, one of the common benign disorder in young females, that's fibroadenoma. First, what you can notice here, nipple appears normal. What else you can notice here? The smooth opacity. And what else? There is a kind of calcification in fibroadenoma. What's the name? Popcorn calcification. Popcorn calcification. So these findings are suggestive of benign disorder. So see, it's very easy to differentiate benign disorders from malignant disorders. First important point is, look at the opacity. If opacity is having regular smooth margin, if it's homogeneous, having low density means the density similar to the breast tissue, and thin halo. What is halo? Halo means empty appearance. These are the findings suggestive of benign disorder. But what happens? Just opposite. If the patient is having irregular margin, what's the problem? If the patient is having irregular margin. Patient is having irregular margin. Like what kind of margin? Stellate margin, spiculate margin, comet tail margin. So what kind of? Stellate margin. Clear? So stellate margin, spiculate margin. These words you have to remember. Stellate margin, spiculate margin, comet tail margin. Right? These words you have to remember. Stellate, spiculate, comet tail margin, because in mammography they mention these words: stellate, spiculate, comet tail. Rest of the things are just opposite. Here homogeneous. So in malignant lesions you will find what kind of lesions? Heterogeneous. So benign homogeneous, malignant heterogeneous. Benign low density, malignant high density. High density. In benign there is thin halo, in malignancy there is wide halo. We discussed that what is halo. Halo means empty appearance around the lesion. Now coming to the calcification, you know what kind of calcifications are seen in benign disorders? Macro. What kind of? It's macro. Macro calcification, you have to remember the size. So this is macro calcification, and the size is more than 0.5 mm. Clear? In malignancy it's micro. It's micro calcification. So this is micro. Micro calcifications, what should be the size? Size should be less than 0.5. How much? Less than 0.5. You have to remember less than 0.5. Right? After that, see the associated changes. Usually, associated changes are absent in benign disorders. And what are the associated changes which are seen in CA breast? We discussed nipple retraction, skin thickening, obliteration of retromammary space. So these will be seen in malignancy. I'm repeating here, very important. So associated changes like there will be nipple retraction, you will find nipple retraction, you will find skin thickening. What else? Skin thickening, clear, and obliteration of retromemory space. So skin thickening and obliteration. Got it? So obliteration of retromemory space. Retromemory space. I'm repeating again. What are the special features? The questions which are asked: irregular margin. What kind of? Stellate, speculate, comet tail margin, and what else? There is microcalcification. Whenever you are sending any patient for mammography, yes, there is BI-RADS score for each breast. What is the full form of BI-RADS? It is Breast Imaging Reporting and Data System. BI-RADS, that is Breast Imaging Reporting and Data System. For each breast, there is a score, BI-RADS score. Now see, if the score is 0 or category is 0, it means mammography is 0. What kind of assessment is there? Incomplete assessment. So what you need? Additional imaging is required. Here what you need? Additional imaging. So here you need another investigation. Additional imaging is required. Category 1, here this is negative. 1 is negative. So what advice should be given to the patient? Come next year. So annual mammography is recommended. Here, annual mammography. So annual mammography is recommended. Category 2, benign disorders are included like fibroadenoma. So even if it's benign, what advice should be given to the patient? Come next year. Annual mammography is recommended. Category 3, it's probably benign, but it is looking benign, but you're not 100% sure. If you're not 100% sure, call the patient for the follow-up. So what? Short-term follow-up. In these patients, what? Short-term follow-up. Call the patient for follow-up. Short-term follow-up. Next, 4. Category 4 is suspicious. And whenever a lesion is suspicious, you have to confirm the diagnosis. How to confirm the diagnosis? For suspicious lesion, biopsy is recommended. We have to go for biopsy. So there can be low suspicion, moderate suspicion, high suspicion. Next, if there is highly suggestive of malignancy, findings are highly suggestive of malignancy. So here, intervention is recommended. So here, intervention is recommended. And some patients, they already have biopsy. Suppose at some peripheral center biopsy has been done, but what? Mammography was not done by mistake. So we have to go for mammography. Here there is biopsy proven malignancy. What are the latest pattern of questions asked in relation to BI-RADS? They ask the risk of malignancy. So in category 0, obviously it's not applicable because it was not assessed properly. In category 1, 2, since it's negative or benign, risk of malignancy is 0%. Probably benign, obviously it's more than 0 to 2%. If it's low suspicion, there is low suspicion, that is 4A. 4A, that is low suspicion. 4B, that is moderate suspicion. 4C, that is high suspicion. So if low suspicion, how much is the risk? More than 2 to 10%. Moderate suspicion, more than 10 to 50%. And if there is high suspicion, obviously the risk is high. How much? More than 50 to 95. And category 5, when it is highly suggestive of malignancy, here, how much is the risk? More than 95%. Clear? So this is BI-RADS. For breast, there is BI-RADS. For prostate, there is PI-RADS. For thyroid, there is TI-RADS. So BI-RADS is for breast. It is based on mammography. Similarly, there is TI-RADS, thyroid imaging reporting and data system. This is for thyroid and it is based on ultrasound or sonography. Then there is PI-RADS, prostate imaging reporting and data system, and this is for PI-RADS, this is for prostate, and this is based on MRI. It is based on MRI. So I'm repeating: BI-RADS for breast based on mammography, TI-RADS thyroid imaging reporting and data system, for thyroid based on sonography, PI-RADS for prostate based on MRI. See the other investigations. First, MRI. You know Angelina Jolie. Her aunt was having breast cancer and she was having BRCA mutation. Angelina Jolie was also having BRCA1 mutation. So any female who is having positive family history or there is BRCA mutation, this female is high risk female. And for high risk females, what is the investigation of choice for screening? Tell me. MRI. So important point, that investigation of choice for screening of breast cancer in high risk females. In high risk females, it is MRI. And what is high risk female? If she is having positive family history, so any female who is having positive family history, or this patient is having BRCA mutation. If the patient is having BRCA mutation, it means we have to go for MRI for screening. Next, investigation of choice for diagnosis of implant related complications. You know, nowadays most commonly used method of breast augmentation as well as breast reconstruction, that is silicone implants. So if a patient is having silicone implant, some complication is there. For that, what is the investigation of choice? MRI. So MRI, investigation of choice for diagnosis of implant related complications. Clear? Implant related complications. So it is implant related complications. Clear? After that, MRI is the investigation of choice to differentiate what? Scar from benign lesions. Differentiate scar from benign lesions. Scar from benign lesions. Clear? So it is scar from benign lesions. Okay? Clear? We discussed just now that first investigation done in a suspected case of breast cancer, that is mammography. What is the problem in young females? If a female age is less than 35 years, these females are having dense and glandular breast. And if there is dense and glandular breast, most of the areas appears black. So this is going to decrease the sensitivity of mammography. So at the place of mammography, if a female is young, age less than 35 years, she is having a lump, here we go for what? Ultrasound. So first investigation done in young females. You have to remember, in young females, age less than 35 years. These two features you have to remember. Age less than 35 years and she's having a lump. Age less than 35 years and she's having a lump. Here, first investigation is ultrasound. Okay, next. PET scan. What's the role of PET scan? We use FDG PET, fluorodeoxyglucose, FDG PET. And this question was asked in one of the latest exam, that what is the most active radio tracer, most commonly used radio tracer in FDG PET? That is 18F. It is 18F, 18 fluorine. So 18F, that's the radio tracer used, right? What's the role of PET scan? You know, it is used for diagnosis of malignancy anywhere in the body, distant metastasis anywhere in the body. So for most of the malignancies, if there is distant metastasis, you can detect it with the help of PET scan. So investigation of choice for diagnosis of distant metastasis. Distant metastasis in most of the malignancies. What is the role in the CA breast? Suppose carcinoma breast patient is there, you perform modified radical mastectomy. After that, after 6 months, patient is coming to you again saying that, sir, I can feel a nodule here. You don't know whether this nodule is a recurrence or it is just because of scarring or fibrosis. Go for PET scan. If there is uptake, it means it's a recurrence. If there is no uptake, it is just scarring or fibrosis. So it is investigation of choice to differentiate what? Investigation of choice to differentiate recurrence, clear, from scarring. So recurrence from scarring, fibrosis or necrosis. From scarring, fibrosis or necrosis. Clear? So that's the role of PET scan. And suppose there is bone metastasis, you suspect bone metastasis. What is the investigation of choice? Bone scan. So investigation of choice for diagnosis of bone metastasis. Bone metastasis, that's bone scan. And we are using one radioisotope for painful bone metastasis, samarium 153. So name of radioisotope we are using, that is samarium 153. It is samarium 153 that is useful for painful bony metastasis. So samarium 153 for painful, it is for painful bony metastasis. Clear? So it's for painful bony metastasis. We already discussed biopsy, investigation of choice for confirmation, investigation of choice for diagnosis of breast cancer, that's biopsy. Nowadays, questions are asked in relation to various types of TNM classification. It's very easy to remember. Have a look. Suppose it is CTNM. The prefix is C. C is clinical staging. So whenever it's clinical staging, like the staging which we do in the wards, that's clinical staging. Suppose you remove the tumor and you send it through pathology department. If there is pathological staging, that is PTNM. So if it is PTNM, that is pathological staging. P, that is pathological. So it is P That is pathological staging. After that, RTNM, this is for recurrent tumors. So RTNM, this is for recurrent. RTNM, this is for recurrent tumors. Clear? MTNM, whenever there are multiple primary tumors at the same site, multiple primary tumors at the same site. So it is MTNM. M, whenever there are multiple tumors. M means multiple primary tumors at the same site. YTNM, this you have to remember. When staging is done after neoadjuvant chemotherapy, if patient has already received neoadjuvant chemotherapy and you are performing the staging, so that's YTNM. So staging after neoadjuvant chemotherapy. So why is TNM? When staging is done, staging after neoadjuvant chemotherapy. So when patient received neoadjuvant chemotherapy. And what is YPTNM? YP. Y means patient has received neoadjuvant chemotherapy and you are doing which kind of staging? Pathological staging. Got it? So it is pathological staging. PTNM. So obviously it is pathological staging done after neoadjuvant chemotherapy. So pathological staging done after neoadjuvant chemotherapy. Now we are going to discuss the 8th AJCC TNM classification, and almost every year in each and every exam you will find minimum one question related to 8th AJCC TNM classification of breast cancer. This is the most important staging you have to remember. So see the staging. First, T staging. What is T1? Size of tumor up to 2 centimeter. So the size of tumor up to 2 centimeter. T2, when the size is more than 2 to 5 centimeter. T3, when the size is more than 5 centimeter. T3, size is more than 5 centimeter. After that, T4A. T4A, there is extension to chest wall. Extension to chest wall. A means under. So breast ke under means extension to chest wall. So there is extension to chest wall. What are the components of chest wall? Chest wall is formed by ribs plus intercostal muscles. So ribs plus intercostal muscles plus serratus anterior. It is formed by ribs plus intercostal muscles plus serratus anterior. Serratus anterior. Clear? So extension to chest wall, that is T4A. Let me tell you, involvement of pectoralis minor and major. Pectoralis minor and major is not the part of chest wall. So involvement of pectoralis minor, major, this is not going to affect the stage. Next, skin changes in T4B. T4B, B means bahar. तो breast के बाहर वाले changes, T4B means bahar. So skin changes. What are those changes? Ulceration, edema including pudgy orange and satellite nodules. So here what we include? Ulceration. So there is ulceration in the breast skin, edema including pudgy orange, edema including pudgy orange, clear? Pudgy orange, and satellite nodules. What? Satellite nodules. So edema including pudgy orange and satellite nodules. Satellite nodules. Clear? All these changes are confined to ipsilateral breast or same breast. So these changes are confined to same breast. Same breast. Yes, it is included in T4B. B means bahar. Skin changes. What is T4C? When both changes are there, T4A plus T4B. So if it is T4A plus T4B, both changes are there, that is T4C. And whenever patient is having inflammatory breast cancer, that is T4D. T4D means patient is having inflammatory breast cancer. This is T staging. Now see the lymph node staging. So whenever there is metastasis to ipsilateral axillary lymph node level 1 and 2, what kind of mobile? It is N1. N1, metastasis to ipsilateral axillary lymph node level 1 and 2. What kind of lymph node? It is mobile. This is mobile. And N2A, whenever the lymph nodes are fixed or matted, same lymph node. Metastasis to ipsilateral axillary lymph node level 1 and 2, but it becomes fixed or matted. So whenever it is fixed or matted, that is N2A. Clear? After that, what is N2B? N2B is clinically apparent internal mammary nodes, N2B. After that, see N3A. There is metastasis to ipsilateral infraclavicular lymph node. N3B, whenever there is involvement of axillary and internal mammary lymph node. And N3C, whenever there is metastasis to supraclavicular lymph node. So, metastasis to ipsilateral infraclavicular lymph node. N3A, metastasis to ipsilateral axillary. This is axillary plus internal mammary nodes. Clear? Internal mammary nodes. Clear? So internal mammary nodes, that is N3B, and we discussed metastasis to ipsilateral supraclavicular lymph node, that's N3C. Distant metastasis is very, very easy. You know, M0 means no metastasis, M1 means distant metastasis. So M0, there is no metastasis. M0, there is no metastasis. M1, these patients are having distant metastasis. There is distant metastasis. Clear? So you have to remember this TNM classification. After that, you have to remember the TNM staging, which is very, very easy. So see, what is stage 1? Stage 1 is T1. What is stage 2A? This is T0 to 1, N1 and T2. What is 2B? Stage 2B, it is T2 N1 or T3. What is 3A? This is T0 to 2, T0 to 2 N2, and this is T3 N1 to 2. T0 to 2 N2, that is T3 N1 to 2. What is 3B? It is T4, T4 N0 to 2. What is 3C? Here, T any T, T1, T2, T3, T4, any T. But if it is N3, it is 3C. And what is stage 4? Any T, T any N, N1, N2, N3. But if it is M1, that is stage 4. Right? Some of you couldn't understand this one. I hope. This one. What is T0 to 2 N2 or what is T4 N0 to 2? Easy. Suppose it is T0 to 2 N2. It means N2 is there. It is T0 N2, T1 N2, T2 N2. Got it? So it's easy for you to write it like this, T0 to 2 N2. So that is T0 N2, T1 N2, T2 N2. Suppose it is T4 N0 to 2. What does it mean? T4 N0 or T4 N1 or T4 N2. Got it? So this is the meaning. So this is the meaning. You got the meaning? Yes? Clear? So this is the meaning. Okay? Some of you didn't understand what this any. So T any T, T1, T2, T3, T4, N any N, N1, N2, N3. But if it is M1, it is stage 4. If it is N3, it is 3C. And when T4 comes, it is 3B. Rest, how to remember? It's very easy. This is 1, 2, 3, 4. So how to remember the rest? 1, 2, 3, 4. It means for stage 1, what is the number? 1. For stage 2A, what is the number? 2. 2B number is 3. 3A number is 4. What does it mean? You can see 1, 1 plus 1, 2, 2 plus 1, 3, 2 plus 2, 3 plus 1, that is 4. Let's discuss it with one example. Imagine patient is having 2 centimeter lump in left breast, 2 centimeter lump. What is the stage? T1. No lymph node is there. So T1 number is 1. Clear? So what is the stage? It is 1. Suppose patient is having axillary lymph node which is mobile. Mobile axillary lymph node. Mobile axillary lymph node. So it is N1. So it is T1 N1. What is the number 2? Number 2 is for stage 2A. So you can see T1 N1. Next, suppose the size of tumor is 5 centimeter. And there is mobile lymph node. 5 centimeter means T2. Mobile lymph node means N1. So number is 3. 3 number is for T2, 2B. And suppose the size of lymph node, it is 5 centimeter, but the lymph node is matted. It is matted. So if lymph node is matted, 5 centimeter T2, matted lymph node N2, 2 plus 2, 4. 4 number is for 3A. So number 4 is for 3A. Got it? So this is how you are supposed to remember. You have to practice and easily you can remember. So I'm repeating again. For stage 1 number is 1. For 2A it is 2. For 2B it is 3. For 3A is 4. And how to remember 3B? T4 is there, it's 3B. N3 is there, it is 3C. And M1 is there, it is 4. 2-3 important points related to staging. Suppose in the same breast patient is having 2 lumps. One is bigger and one is smaller. How will you stage? So staging should be done according to the size of bigger lump. Suppose patient is having 1 lump in each breast. So for each breast, staging should be done separately. Suppose there is a lump in the right breast, but there is involvement of lymph node in left axilla. Right breast lump, involvement of left axilla means whenever there is contralateral lymph node involvement, it is suggestive of what? Metastasis. This is one aspect. Nowadays in exams they are asking that what's the minimum number of lymph nodes or adequate number of lymph nodes removed for adequate staging. Okay, so how to remember? For gallbladder, G means gallbladder, how many lymph nodes? 6. For B, for breast, how many lymph nodes are removed? Breast, 10. C means colon, R means rectum. C, colon, R means rectum. So clear? Colon and rectum. Can you tell me how many lymph nodes are removed for adequate staging? 12. For esophagus, 15. ST means stomach, 16. So for esophagus, we are going to remove how many lymph nodes? 15. And for stomach, we are going to remove how many lymph nodes? 16. So how to remember? Mnemonic is GB crest. It is GB crest. Clear? So this is GB crest. G gallbladder 6, B breast 10, colon rectum 12, esophagus 15, ST stomach 16. Clear? This is the latest question in one of the latest exam. Now see the most important aspect of breast cancer, that is management. Suppose patient is having early invasive breast cancer. Can you tell me what's the stage? In early invasive breast cancer, the stage is 1, 2A, 2B. So stage is 1, 2A, 2B. In these cases, what is the preferred treatment option? We go for breast conservation surgery plus sentinel lymph node biopsy plus radiotherapy. So it is breast conservation surgery plus sentinel lymph node biopsy plus radiotherapy. Suppose there is some contraindication to breast conservation surgery. If contraindication is there, in that case we go for simple or total mastectomy. So that is also known as simple or total mastectomy. Apart from that, we perform sentinel lymph node biopsy, that is also known as axillary lymph node sampling. Got it? Suppose you are removing the tumor, you are sending this tumor to pathology department. From pathology department, you get a biopsy report. From biopsy report, what you can see that the size of tumor is more than 1 centimeter, or lymph node is positive, or size is more than 0.5 centimeter, lymph node is negative, but there are adverse prognostic factors. What are those adverse prognostic factors? If patient is having high histological grade, lymphovascular invasion, hormone receptor it's negative, and HER2 new is positive. Out of these 4, any one is positive. So in all these, if any one is positive, in those cases we have to give chemotherapy after surgery. And what kind of chemotherapy is this? Tell me. Adjuvant. So chemotherapy is given after surgery on the basis of biopsy report. This is adjuvant chemotherapy for which patients? For early invasive breast cancer. Clear? Next. Suppose patient is having locally advanced breast cancer. Tell me the stage in locally advanced breast cancer. This is known as LABC. Stage is 3A. This is 3B and 3C. So stage 3A, 3B, 3C. Okay, what we do? We go for neoadjuvant chemotherapy. So treatment option here, neoadjuvant chemotherapy. You tell me why. Neoadjuvant chemotherapy is given to downstage the tumor. So neoadjuvant chemotherapy for downstaging the tumor. After that you resect the tumor and the breast also, that is MRM, modified radical mastectomy. And after MRM you have to give radiotherapy. Why radiotherapy? For loco-regional control. So plus radiotherapy for loco-regional control. This is the treatment for locally advanced breast cancer. Now coming to the metastatic breast cancer, you tell me what's the stage? Metastatic breast cancer, that is stage 4. What we have to do in metastasis? First, we have to prolong the survival, because we know that patient is having limited survival. Not only we are going to prolong the survival, we have to improve the quality of life of the patient also. So what? Prolong the survival as well as improve the quality of life. We have 2 options. We can give hormone therapy also, chemotherapy also. What is the problem with chemotherapy? You know, chemotherapy is toxic. Side effects are more. So hormone therapy is preferred, but there are indications in which we are going to give hormone therapy. There are indications for chemotherapy. In which cases we are giving hormone therapy if ER/PR is positive. Patient is having asymptomatic visceral metastasis, or there is bony or soft tissue metastasis. Got it? No need to remember the chemotherapy indications. It is just opposite. So first, can you tell me? ER/PR, obviously negative. There, it is asymptomatic visceral metastasis. So what will be the indication in chemotherapy? Tell me. Symptomatic. What is that? It is symptomatic. Clear? So that is symptomatic visceral metastasis. Clear? So this is symptomatic visceral metastasis. There, bony or soft tissue metastasis if patient is not responding to hormone therapy, that is hormone refractory. So if the tumor is hormone refractory, when the tumor is hormone refractory. Clear? So if it's hormone refractory, in those cases we are giving what? Chemotherapy. Clear? Indications of hormone therapy, chemotherapy. Okay, so till now we discussed many indications of radiotherapy also. Tell me, first, in the breast conservation surgery, since you are conserving the rest of the breast tissue, there are high risk of recurrence. And since there is high risk of recurrence, what? To prevent the recurrence, you give radiotherapy. So first, breast conservation surgery. Why we were giving radiotherapy in locally advanced breast cancer? Tell me, loco-regional control. So for loco-regional control, in the breast cancer staging, what did you notice? We didn't mention the number of lymph nodes. So what is the importance of number of lymph nodes, positive lymph nodes? Whenever 4 or more positive lymph nodes are there, here we give radiotherapy. And if after surgery some amount of tumor is still left, margins are positive, so to kill tumor cells we give radiotherapy. So indications are breast conservation surgery, locally advanced breast cancer, 4 or more positive lymph nodes and positive margins. Next, chemotherapy regimens. Let me tell you, every year there is at least one question from the chemotherapy regimens. Sometimes in pharma it is asked, sometimes in surgery it is asked. First, see the chemotherapy regimens. One is CMF and the second is CAF. What is CMF? Cyclophosphamide. M means methotrexate. So cyclophosphamide, methotrexate, 5-fluorouracil. And what is CAF? C and F is same. A, that is adriamycin. Can you tell me what are the other names of adriamycin? You know, adriamycin is also known as doxorubicin. This is doxorubicin. And you know that this is anthracycline derivative. What? This is anthracycline. Got it? So this is anthracycline derivative. So tell me, which one is preferred? Methotrexate based chemotherapy or adriamycin based chemotherapy? So you know, it is the adriamycin based chemotherapy which is preferred, right? So this is adriamycin based or anthracycline derivative based or doxorubicin based chemotherapy which is preferred. And you know how many cycles are given? We are giving 6 cycles. So how many cycles of chemotherapy are given? It is 6 cycles. Suppose you are giving adriamycin, there is no response. So this is adriamycin resistance. For adriamycin resistant breast cancer, which agents are given? Can you tell me? Toxic agents. Which one? Taxanes. We are giving taxanes. And tell me the agents. Taxanes, docetaxel, paclitaxel. Name of agents, these are docetaxel, paclitaxel. So it is docetaxel, paclitaxel. Okay. Suppose there is resistance to both, resistance to adriamycin also, taxane also. So if adriamycin and taxane resistant breast cancer is there, we give a new drug, relatively new drug, and you must remember the name. What's the name? It's ixabepilone. So name of this drug, this is ixabepilone. Clear? In the latest exam, they asked HER2 new positive breast cancer. And what is the first line agent? It starts with HER2 new, Herceptin. So first line agent is Herceptin. It is Herceptin, and you already know what is the other name of Herceptin. It is trastuzumab. What's the name? Name is Trastu. Clear? So this is trastuzumab. It is trastuzumab. And can you tell me the second line agent? This was asked in one of the latest exam. Lapatinib. The second line agent, that's lapatinib. And in one of the latest exam, the question was asked that refractory and metastatic breast cancer, refractory means it is not responding to any other agent. So for refractory and metastatic breast cancer, we are using which drug? Sunitinib. So what? For refractory and metastatic breast cancer, we are using sunitinib. It is sunitinib. Sunitinib, this is for refractory and metastatic breast cancer. You know? Refractory and metastatic breast cancer. Metastatic breast cancer. So for refractory and metastatic breast cancer, we use sunitinib. You know what are the other uses of sunitinib? For GIST, first line agent is imatinib, second line agent is sunitinib. So for imatinib resistant GIST, we give sunitinib, and for first line agent for advanced and metastatic RCC, we give sunitinib. So sunitinib, second line agent for GIST, given for imatinib resistant GIST, and it's the first line agent for advanced and metastatic RCC. Now let's discuss the concept of hormone therapy. Yes, see, the breast cancer cells, on the breast cancer cells, the estrogen is having positive effect. So estrogen is having positive effect on breast cancer cells. So in the management, we can go for ovarian ablation, means we can go for bilateral oophorectomy, remove the both ovary, or you can go for LH-RH agonist, means medical oophorectomy, we give goserelin and leuprolide. Clear? One thing. Or you can block the receptors. How you can block the receptors? By selective estrogen receptor modulator, tamoxifen, raloxifene. One concept is clear. Either you can go for ablation, medically or surgically, or you block the receptors. Right? Next, suppose premenopausal female is there, ovary is the main source of estrogen production. But in postmenopausal females, ovary is not producing estrogen. Estrogen is being produced by fatty tissue by peripheral aromatization. So if estrogen is being produced from fatty tissue by aromatization, we can give aromatase inhibitors. So can you tell me, aromatase inhibitors can be given in both premenopausal as well as postmenopausal females, or only postmenopausal females? Only postmenopausal females, because aromatization is main pathway, especially in the postmenopausal females. So one by one, what are the options we have in hormone therapy? We can go for ovarian ablation, bilateral oophorectomy, or we can give LH-RH agonist. What are the agents? Goserelin. We can give goserelin or leuprolide. Leuprolide. Clear? Leuprolide. Another option we have SERM, selective estrogen receptor modulator. What are the agents we have? Tamoxifen. We can give tamoxifen, or the second agent we have raloxifene. So it is tamoxifen or raloxifene. We can give aromatase inhibitors. What are the non-steroidal agents? These are letrozole and estrozole, non-steroidal. Letrozole and anastrozole. Non-steroidal. What are the steroidal agent? Steroidal agent is exmesten. Sometimes in exam this question is asked, in gynae, in pharma, in surgery also, that what are the steroidal agents? How to remember? Yes, steroidal is exmesten. Now I hope you will not forget now. Steroidal is exmesten. Clear? Anti-estrogen, there is a single agent which you have to remember. The name is fulvestrant. It is fulvestrant. And progestins, here we give megesterol and medroxyprogesterone acetate. So progestins, we give megesterol. And medroxyprogesterone acetate. Medroxyprogesterone acetate, I'm repeating the question. What is the drug of choice for hormone therapy in premenopausal females? Tamoxifen. In postmenopausal females, it is aromatase inhibitors. So you can see here, for premenopausal females, we give tamoxifen. That's the drug of choice. And for postmenopausal females, we give aromatase inhibitors. What we give? Aromatase inhibitors. Clear? So this is aromatase inhibitors. Can we give tamoxifen in postmenopausal females? We can. But what is the problem? Tamoxifen is having partial agonistic action on uterus. So what? It is going to increase the risk of? It is going to increase the risk of endometrial cancer. And you know that in postmenopausal females already there is increased risk of endometrial cancer. That's why we don't give it. So tamoxifen, how much is the dose? We give 10 mg BD. And that 10 mg BD is given for 5 years. Right? It is having potent antagonistic action on BB. Potent antagonistic action on BB. BB means breast cancer cells and blood vessels. BB. Breast cancer cells. Clear? So breast cancer cells and blood vessels. Clear? So husband and wife BB are usually antagonistic. So antagonistic on BB, right? Breast cancer cells, blood vessels. Now see the partial agonistic effect. How to remember? Pitbull. You know the pitbull? Singer? Pitbull. So pit means pituitary. That is pituitary. B, there is bone. U, uterus. L, liver. bone, uterus, liver, and we discussed that it is having partial agonistic action on the uterus, and because of that there is increased risk of endometrial cancer, and that's why we are avoiding this in postmenopausal females. So because of this there is increased risk of endometrial cancer. Endometrial cancer. So I'm repeating the question again. This was asked many times. Drug of choice for hormone therapy in premenopausal females, tamoxifen. In postmenopausal females, aromatase inhibitors. Clear? Now let's discuss the MCQs. That's very easy. You can see patient with invasive ductal carcinoma in situ. What? Invasive ductal carcinoma in situ. What's the problem in this patient? Ulceration on skin. There is ulceration on skin and inflammatory signs. So ulceration on skin and inflammatory signs. Nipple retraction was also present. What is the stage? Clear? So if there are inflammatory signs, there are ulceration also. So if inflammatory signs are there, it can be inflammatory breast cancer. If inflammatory signs are there involving more than 1/3 of breast skin, so this is inflammatory breast cancer. And inflammatory breast cancer is T4D, and T4D, it corresponds to stage 3B. Stage 3B, right? So what? No metastasis. T4B, no T4B, it is for ulceration, edema, satellite nodules. Stage 4, no, it's not stage 4, it is stage 3. So what is stage? Stage is 3B. So inflammatory signs are there, so patient is having inflammatory breast cancer. T4D corresponds to stage 3B, and that is stage 3. Clear? So correct answer is A. See this question. 50 years old lady presents with progressive painless lump in the breast. What is the cause of following skin changes? Can you see what's the change? This is pure orange. You can notice. This is pure orange. And you know that whenever there is pure orange, what is the stage? T4B. It is because of lymphatic permeation or obstruction. So lymphatic permeation or obstruction by tumor cells. So what's the cause here? Can you see? Infiltration of subdermal lymphatics. Correct? Infiltration of duct. Incorrect? Involvement of ligament of Cooper. It is seen in dimpling. So this one is seen in dimpling and puckering. So it is seen in dimpling and puckering. Spread of tumor to anterior chest wall. No. So correct answer is A. This kind of question is asked almost every year related to pure orange. Now see this question. A 25 years means a young female, 25 years old woman presents with breast lump. There is a lump. There are no skin changes or induration. Young female, breast lump is there, no skin changes or induration. On histology, it's fibroadenoma. Which of the following category does it fall? So fibroadenoma, you know, it's a benign lesion. It's a benign lesion. If you see Byret's category 0, incomplete assessment, 1, negative, 2, benign, 3, probably benign. Category 4 is suspicious. Category 5, highly suggestive of malignancy. Category 6, biopsy proven malignancy. Okay. So category 1, it's negative, and 2, no, it's not both. Category 2 or 4, obviously not, because it's not suspicious. Category 2, 3, 4, it is category 2 only. So what is the correct answer? It's benign, so it is only category 2, Byret's 2. Clear? So correct answer is what? Byret's 2 is fibroadenoma. It's benign, it's Byret's 2. Now see this question. A lump in the breast is observed in a female patient. So female patient is having a lump. Among the options listed below, all but one can be employed to exclude the presence of cancer. Which one is not applicable for this purpose? So usually how, if a patient comes to us, we go for triple assessment. What are the components of triple assessment? Yes, clinical, signs and symptoms, imaging, tissue sampling. So clinical examination, radiological investigation, histology and cytology. PET scan is not the part of triple assessment. So A, C, D are the parts of assessment. B is not the part. So correct answer is B. Next question, you can see 52 years old female presents with HER2 new positive breast cancer and has become resistant to trastuzumab, because for HER2 new, you know, the first line agent is trastuzumab. The oncologist considering next line of treatment for this patient. Which of the following option would be the most appropriate choice? You know, for HER2 new positive breast cancer, first line agent trastuzumab or Herceptin, and the second line agent is lapatinib. So the second line agent for HER2 new positive breast cancer, that is lapatinib. Now see this question. Which of the drug used for estrogen dependent breast cancer? Means for hormone therapy, which drug is used? Obviously for hormone therapy we are giving what? Tamoxifen. So if it is estrogen or progesterone receptor positive hormone receptor is positive, we are giving tamoxifen. Clear? So correct answer is C, tamoxifen. So this is all about breast part 1.